مرحبا ويعطيكم العافية. اليوم محاضرتنا عن Interdisciplinary Treatment Principles of Orthodontic, Restorative and Orthodontic Periodontal Treatment. The reference for this lecture is an article I uploaded to the e-learning as well, plus the lectures. It's a combination of both of them. So today we're going to talk about how do we, in orthodontics, help our colleagues in periodontics and restorative dentists to a treatment for their cases. So basically, let's start with talking about hypodontia. So hypodontia is a developmental absence of one or more primary or secondary teeth, excluding third molar. How common is hypodontia in Jordan? Now, according to the study done by our colleague Dr. Mariam Al-Abdallah, it said that hypodontia prevalence in Jordan is 3.7% of the cases. So in this lecture, we're going to discuss management of hypodontia and many ortho-restorative and perio-ortho-restorative cases. Cases such as this one with missing central incisor and unerupted canine. We can treat her to be something like this, and cases with the missing lateral incisor and a big shaped lateral incisor on the other side to be treated to be something like this. So in this lecture, we're going to discuss all the treatment options. So whenever we have a hypodontia case, the treatment will be either orthodontic treatment alone, or restorative treatment alone, or which is going to be a replacement of the space with an implant, with a bridge, with a build-up, or denture, and plus and minus crown lengthening surgery. And the last option is combined ortho and restorative treatment, which have the same options of implant, bridge, build-up, and denture. So basically, when we do orthodontic treatment alone, we are aiming to close all the spaces for the missing tooth or missing teeth, so that at the end of the treatment, there is no need for a replacement of the missing tooth with an implant or denture or whatever. So we don't need any restorative treatment. But in some cases, we cannot do that, so we have to combine the orthodontic treatment with the restorative treatment, in which we open the space for a missing tooth for the restorative dentist to place the implant or the bridge. But sometimes as well, the space is good enough from the beginning that the restorative dentist does not need the help of orthodontist to open the space or redistribute the space for the future placement of the prosthesis. So which option are we going to go for? How are we going to decide which option to treat? So I'm going to now show you a couple of cases, and during the cases I'm going to explain how did we think during that treatment, and what are the points that we focus on, and these are the things that you need to consider. So you can see this patient here, he's smiling, and you can see that the central incisor, lateral incisor on the right side erupted, and the central incisor, lateral incisor on the left side has erupted as well, but there is a space indicated a missing central incisor, and this is intraorally. And you can see here that we have a tooth that is erupting in the mucosa. In fact, this tooth is a supernumerary tooth that blocked the eruption of the central incisor. That the central incisor now, the upper left central incisor, is impacted just near the nose, which is very difficult to align. And if we decided to go for the exposure, it's going to be a very traumatic surgery. So we decided that we can use this supernumerary tooth for now, at least, until the patient is older, that he can replace it with an implant in the future. Or if the tooth stay as it is, he can keep it as long as it is possible. So this patient has a couple of problems. He has a missing central incisor, we have supernumerary, and he has a high canine on the left side and small space for the upper left central incisor. So how are we going to manage this patient? So first, when we do examine the patient, we have to look at the incisor shown smiling. And why is that important? Because when you have increased or high incisor shown smiling, that means that all the teeth are exposed. So you have to be very careful during the treatment, that it has to be perfect. I don't mean that we don't do perfect treatment. I mean that we do not compromise and accept a compromised option. So if the patient has a low incisor show at rest, the patient will be more forgiving, meaning that If the gingival margins are not leveled, he will not be unhappy. He will be happy because he can't see them. But if the patient show all the incisors during smiling, he will not be happy to tell him that the gingival margin will not be the same in both sides. Second thing that we have to consider is the gingival margin for the teeth. So if you look at the supernumerary tooth that we plan to replace the central incisor, it has a high gingival margin compared to the central incisor, plus the position of the tooth, for sure. And it's the same for the upper left canine. So for this patient to be treated, we have to bring these teeth down and to bring the gingiva with them as well, so that at the end of the treatment we have an even gingival margin. You have to look at the midline. So if you look at this patient here, that we have a midline shift in the upper. So upper and lower midline should be constant. Now, usually and generally speaking, then orthodontists detect midline shift less than 2 mm. Dentists detect midline shift if it is 2 mm and above, while lay people consider they can see midline shift if it's between 2 and 4 mm. So midline shift can be accepted if it's less than 2 mm. If it's more than that, we have to correct it. So here the patient has a midline shift in the upper, the midline shift in the lower, the midline in the lower is correct, but the upper midline is shifted to the left. And you have to consider the space available, and this is a very important one, because the space for the missing upper right central incisor is much smaller than the upper left central incisor. And one of the most important things to achieve a good or aesthetically acceptable result is to have an equal symmetry, which means that we have to have an equal size of the upper right central incisor and an equal size of upper left central incisor. If we restore the tooth in this small space, it will look ugly. The patient will never like it. And this is one of the key factors when we have to do an orthodontic treatment before the restorative treatment, is the space redistribution. So here, for example, again, the upper right central incisor does not have enough space, or does not have space in similar to the one on the left side. So we have to enlarge the space here. So treatment now planned for this patient is to start orthodontic treatment first, with the aim of aligning the gingival margin and aligning the supernumerary tooth and the upper left canine, correction of the midline shift, and create enough space for the upper left one to be similar to the upper right one. Then to do restorative treatment. So then this is how he finished the orthodontic treatment. As you can see from where we started, we have a higher gingival margin that is corrected, we have a midline shift that is corrected, and we enlarge the space for the supernumerary tooth to be similar to the one on the left side. As you can see, the gingival margin, the midline, and the space. So now he is done with the orthodontic treatment. Is he going to go now for restorative treatment? Well, first of all, before he starts the restorative treatment, we need to evaluate the gingival margin. And the reason for that, because patient is showing all the incisors during the smiling, so he will notice any difference in the gingival margin. So as you can see here, on the upper right central incisor, the gingival margin is covering part of the central incisor that need to be adjusted. And on the canine, on the right side, the gingival height is not equal to the height on the left side. So we need to do crown lengthening on the upper right central incisor and on the upper right canine to look symmetrical. And that's him after the periodontal surgery is done, crown lengthening surgery done by Dr. Shakman. And you can see that the gingival margin is fine on the upper right central and upper right canine. Now the patient is ready to go for a restorative replacement, either going to be a crown, which is more aggressive, or conservative option of veneers. Dr. Abu Awad decided to go for a veneer, and veneer is placed. So now you can see the result. We have nice teeth. Only one veneer is placed on the upper left central incisor. So the key point to have a successful treatment is to do a proper planning from the beginning. You need to focus on the amount of space available. You need to focus on the incisal show on smiling, so to know that how much forgiveness do you have from the patient, and to look at the gingival margin and to make sure that they will have an equal gingival margin. This is him before the restorative treatment. So the treatment went from the beginning, when we have no enough space, we have a high central supernumerary and canine, midline shift, orthodontic treatment, adjusted all that, then periodontal treatment to make the gingival margin look fine, then finally the prosthodontist to place the veneer and do bleaching for the patient. So all these one guarantee that you will have good results. The second topic to be covered is the missing lateral incisors. Now, when we have a missing lateral incisor, and it's very common, we have one of two options. Either space closure, which is an orthodontic treatment alone, or a combined restorative and orthodontic treatment in which we do a space opening. So, in the space closure, basically the canine will take the place of the lateral incisor. While in the space opening option, the canine will take their places and we open the space for the lateral incisor to be replaced with an implant, bridge, or build-up. So you can see in the photographs here, on the right side, we have a missing lateral incisor. And the canine took the place of the lateral incisor that is missing. So if I'm going to look carefully at this photograph, it's good enough, but as you can see, the canine is big, and it's bigger than the lateral incisor on the left side. And the color is darker. The canine is more yellowish, while the lateral incisor on the left side is lighter in color. Now, this is a photo from a textbook. So basically, if we decided, or one of the factors that we need to decide, and we need to think about when we decide whether to space closure or space opening, is the canine. Meaning, if we have when you do space closure, you need to think that this canine is going to replace the lateral incisor. So we have to look at the color of the canine. Is it dark yellow color? Is it whiter color? If it's a whiter color, then it's more similar to the lateral incisor, then we are fine. And is it big canine? If it's a big canine, it's hard to make it look like a lateral incisor. And what about the cusp tip? Is the cusp tip pointed for this canine or not? So we have to look at all these things with the canine to make sure if it's going to look like a lateral incisor or not. Our life will be much easier if the missing lateral incisor is bilateral. Meaning, if the lateral incisor is missing in both sides, so space closure will be easier because we have the canine on both sides to be reshaped to look like a lateral incisor. So again, it will be symmetrical. And again, symmetry is one of the most important things to consider when you do treatment planning for this kind of patient. So for this patient here, space closure could be done because simply the canine is small, it's white in color, we can easily reshape it, and it's bilateral. So when we reshape the canine, it's going to look the same on both sides. While the canine here, it's unilateral. We have a lateral on one side and canine on the other side. The canine is big, it's darker in color, and it's pointed tip. So it would be more appropriate to do space opening here and space closure here. Things as well to consider during the decision of space opening or space closure is the amount of space. So again here, although in this textbook photograph the space is closed, but maybe because we don't have enough space to open from the beginning, which means if we decided to open space for the lateral incisor, we need to extract a premolar, which is kind of ironic because you don't want to extract a tooth that is a natural tooth to replace it with a prosthetic tooth. It's the same as here. We have a median diastema that's maybe 3.5 millimeter, and this diastema is not enough to the spaces of the diastema is not enough to replace a tooth. So basically, if I decided to treat this patient with space opening, I have to consider extraction. So I have to consider extraction of two premolars, one on the right, one on the left, and this extraction space will be closed by the canine moving distally, and then I have to place an implant in the place of the lateral incisor, which is I consider really ironic because we don't really extract a natural tooth to be replaced with a prosthetic tooth. So far, what we need to consider during space opening or space closure is the shape of the canine, the color of the canine, the size of the canine, the amount of the spacing present in the dentition, whether it's unilateral or bilateral, the amount of the incisal shown smiling, as we said before, because when we have a high smile line, then we have to do everything perfect, while if we have a low smile line, we can compromise the treatment. Again, if you can see this patient here, this is in the bottom is an occlusal photograph. So we can do a little bit of charting starting from the upper left 7, 6, 5, 4. Then we have a C, an upper left canine, which is erupted in the place of the missing upper left lateral. Then we have upper left central, and on the right side, all the teeth are present. If you look to the front view on the top, you can see that the canine is pointed tip. It's big compared to the smaller lateral incisor on the right side. So we have a canine that is big, pointed. We have a unilateral missing tooth. We have a small lateral incisors. And we have a C, which means if we extracted this C, we have plenty of space. So this case is indicated immediately for space opening rather than space closure. Because simply we need the space of the C, because eventually we're going to lose this C and it's going to be a space, so there will be an implant. So it's better to place the implant in the place of the canine, in the place of the lateral incisor, instead of placing it in the place of the canine. So if we decided to do a space closure, which means that the canine has to look like a lateral incisor, so what do we have to do for it? First, we have to extrude the canine. So when we extrude the canine, the gingival margin will follow. So now we will have a gingival margin of the central incisor, then the canine, which will be a future lateral incisor, will be 1 millimeter more gingival because we extruded the tooth. Okay, then we have to do, after we extrude the canine, we have to do trimming for this canine to look like a lateral incisor. So this is again a textbook photograph. So you can look, our aim usually is to have the central incisor and the premolar, which is to be a canine, at the same level, and the lateral incisor is 1 millimeter more gingival. So in this photograph, as you can see, the lateral incisor is extruded and it's trimmed incisally. So the canine, which is now a lateral incisor, is fine. But if you look to the premolar gingival margin is low. It's equal to the gingival margin of the lateral incisor. And that should not be the case. Lateral in the canine, or now it's the first premolar here, gingival margin should be in line with the central incisor. So what we have to do in these cases is to intrude the first premolar. Okay, and when we intrude the first premolar, the gingival margin will follow. And now we have the gingival margin that is similar to the central incisor. Then we do either a little bit of composite buildup to increase the length, because usually the length of the canine is longer than or the height of the canine is longer than the height of or the length of the first premolar. So what you need to do is to do intrusion. The gingival margin will be fine, and then we have an extra 1 to 2 millimeter of space occlusally that we will do it with an onlay, composite, or porcelain restoration. Now, the mesodistal width of the premolar is smaller than the mesodistal width of the canine by 1 to 2 millimeter. So to mask this, what we do is to rotate the premolar slightly mesobuccally, and this rotation will increase the space occupied by the tooth, and by that, the first premolar will look like canine. And this is how the patient looked like after the finish of the textbook photograph. And as you can see, that the lateral incisor, or the canine now, it looks like a lateral incisor. It's darker in color, but because it's symmetrical, it's fine. And that's why I'm talking about the asymmetry. Now, if we have a lateral incisor on the left side that is not missing, and the canine that is replacing the lateral incisor on the right side, you can detect a difference. But because here it's symmetrical, you can consider, oh, this is a nice result, and I can do bleaching for the whole arch, and it will be the same. And as you can see, for the first premolar, it's intruded, crown lengthening is done, and a little bit of a composite build-up to increase the height of the fore, so now it looks like a canine. So these I have to do when we consider space closure. One thing more to consider as well for if you decided to go for space opening or space closure is the male occlusion, which means if the patient has a class 2 skeletal relationship with increased overjet. In this kind of patient, if we have a missing lateral, we tend to close the spaces, generally speaking, I'm saying, because we use this space to reduce the overjet, to retract the upper incisors and reduce the overjet. And it's the other way around if the patient has a class 3 malocclusion. So basically we need to do anything possible to procline the upper incisor to compensate for the class 3 relationship. So in a class 2 patient we tend to do space closure, while in a class 3 patients we tend to do space opening. And we can see now an example. This patient, extraorally, she looks like a class 2. And intraorally now, you can see that she has 2 central incisors, but we have a missing lateral incisor on the right side, and we have a big shaped lateral incisor on the left side, and we have plenty of space distal to the canine. So what we need to do for this patient now, because we have plenty of space, and we have a big shaped lateral on one side, is just to distalize the canine. This patient is not eligible for space closure because simply we have plenty of space distal to the canine. And we have a big shaped lateral on the left side, so it makes sense to distalize the canine and then place an implant in the place of the lateral incisor. So what we can do is to push the canine distally, create space for this lateral incisor. And here is another thing to consider for space opening and space closure is the protrusion of the profile. If the patient has a protrusive profile, which means that all the teeth are protruded, we tend to do space closure because we want to retract and reduce this protrusion. But if the patient has a retrusive profile, like this patient here, we tend to do anything to give support to the lips, which meaning we do space opening instead of space closure. So we don't need anything to be shuffled back. So for this patient now, we need to retract the canine distally to occupy the space of the extracted C. We have to maintain the midline and correct the midline shift because the lower midline is correct, but the upper midline, the upper right central incisor is correct, while the upper left incisor went to the left side, so we have to bring it back. So now our treatment plan is to distalize the canine, open space for the lateral incisor, make the space on the left side of the big shaped lateral incisor enough and similar to the one on the right side, and correct the midline shift. So we need to retract the canine back into class 1 with all the spaces. In these cases we have to reinforce anchorage with here because if we retract the canine, the reactionary forces will be movement of the 4, 5, 6 forward, which is we can't allow in this case because we have to move the canine a long distance. So for that reason, what we need to do is to reinforce the anchorage with that. If you can look, the power chain here, the pink one, is attached to the mini screws in the gingiva rather than to the tooth. So now we can retract the canine without any problem. And why is that important? Because if you see this case here, it's a textbook photograph again. On the right side and the left side, we have enough space for the placement of the canine. But if you look carefully to the roots, we can see that the canine root is upright and the lateral central incisor as well. So now if you try to place an implant, you can't do that. You have enough intercrown space, but we don't have enough interradicular space. And we call this a wagon wheel effect. So what is the wagon wheel effect? When you push the teeth away from the bottom, the roots will meet in the top. And now if the orthodontist or the prosthodontist try to place an implant, he can't do that. And that's what happened with this patient. Implant on the left and Maryland bridge on the right. Or sorry, it's the other way around. I'm sorry for that. So for here, it's an implant on the right and Maryland bridge on the left side. Back to our patient, this is how she finished. Forgive me about the oral hygiene. This is the case and most of our patients on the hospital, they kind of, yeah, when you reach the end of the treatment and the oral hygiene is just terrible. Anyway, so we did a little bit of scaling at the day of the debond. As you can see now, the midlines are coincident. The canines is class 1. We have a space that is created for the missing upper right lateral, and we enlarge the space of the big shaped lateral on the left side. Canine is a class 1 on both sides, molar is a class 1 on both sides. Now that's how she finished. Now definitely this is not how the patient would like to look like, and the gingiva is not good enough to go for a restorative treatment. So now she needs to go for a periodontal treatment, and this periodontal treatment first started with the phase 1 of treatment, which is stabilization. So oral hygiene instruction is given to the patient. As you can see, the redness has disappeared, and but still we have a hypoplastic or hyperplastic, so the gingiva. We have a gingival growth and the central incisors near the missing lateral on the canine as well. So this patient needs a crown lengthening surgery before we go for restorative treatment. So this is the wax up for her to see the amount of the gingival margin. Then TSD and crown lengthening surgery is planned, and the patient then went for a crown lengthening surgery. As you can see, this is here before and after the crown lengthening surgery. Now we waited for the crown lengthening surgery to heal, and now the patient is ready for the treatment. Now, when we have a missing lateral incisor, the restorative options are either a Midline bridge, if we don't have enough interradicular space, or as is this one, or you can go for a partial denture, or the best option is to go for an implant. So to our case now, again, this patient is treated with an implant on the right side and veneers on the left side. So implant was placed by Dr. Murad, veneers is done by Dr. Mu'tasim, and this is how she finished. So proper planning from the beginning is good to guarantee good results. Now, the other way to do an ortho-restorative treatment is when we have a tooth like this. So we have a big restoration here, as resulted in patient did not go for a crown, and then while he's eating fractured the lingual wall. When you took the lingual wall off, we can see that the fracture line is way subgingival. The tooth was root canal treated before, and it's a good root canal treatment. So the patient now is given the option of extraction and replacement with an implant, which is a very fair option. But the patient doesn't like any prosthetic tooth. And in the same time, we can't do a crown lengthening surgery, and we can't place a restoration to start with, because we want to have furrow effect, and if we're going to get furrow effect, you're going to violate the biological width. And we can't do crown lengthening surgery because simply the fracture line is about 2-3 millimeters subgingival. So if Dr. Shahman going to do, or the periodontist is going to do the crown lengthening, he's going to jeopardize the periodontal support of the neighboring teeth. So what is the option? Is to go and do orthodontic extrusion. So we bonded only 3 teeth and we extruded the first molar. So if you can look at the photo on the left and the right, you can see the amount of the extrusion. Look at the gingival margin of the central inside of the first molar and compare it to the second premolar. You can see on the left photograph that the gingival margin is almost equal before we started the treatment. But after we started the treatment, the height of the gingival margin difference is about 2/3 of the height of the first premolar, of the second premolar, which is about 3 to 4 millimeters. And this is the amount of the extrusion that we did to bring the gingival margin of the fracture line supragingival. So now it's come the job of the periodontist here. As you can see, the amount of the extrusion we did. So now the periodontist can simply do a flap, do crown lengthening, exposing the fracture line, and then closing the flap. So this is how the patient look like after the periosurgery, and then the prosthodontist can see here, you can see the margins, all of them are supragingival. He can simply do the restoration and then the crown for the patient, with all the margin of the restorations are supragingival. So this is another way how ortho, perio, restorative dentist can work together. Another case in which ortho and restorative can work, when we have an adult patient and previous extraction, as you can see on the left side, the upper first and second molar has extruded. Now, if you can see that if any restorations to be placed in the lower jaw, they can't be placed because we don't have enough interocclusal space. Because this patient has a lower molar extracted ages ago, resulted in extrusion of the upper molars. So all what we need to do now is to intrude these molars to allow enough space for future implant or restorative replacement. So as you can see here, we don't have enough interocclusal space. So this patient was treated with fixed appliance using mini screws to reinforce anchorage, and then we intruded the molars, and this is the result. The molars are intruded and we have enough interocclusal space for future replacement. As you can see the difference between the photograph before and after. Now sometimes as well we need the help of the restorative dentist. As you can see for this patient, she has a kind of rotated or tilted upper left central incisor. If we take an OPG, we notice that she has a dilaceration with the root dilacerated of the upper left central, dilacerated mesially, touching the mesial side of the upper right incisor. And when we took a cone beam CT scan, they were in a tight contact. So I can't upright this tooth, because if I upright it, the root will immediately hit the root of the lateral incisor. So if you can notice, we started the treatment without engaging the central incisor, and then we closed all the spaces and referred the patient to the prosthodontist to reshape the central incisors, and that's how it's done. Thank you very much for your listening. Remember that teamwork is the key for the success. Thank you.